Preston with Idaho 2Fly.
My name's Steve Drabeck, and I'm also with Idaho 2Fly.
Today we're out at Idaho Urologic Institute, continuing our series of videos about cancer. We're hoping to have a whole library as a good resource for you folks with cancer.
And our next part of this series is we're going to be filming on bladder cancer. And Dr. Klo will be the speaker here in a few minutes and coming out and talking about the various aspects of bladder cancer.
We're really looking forward to this video to add to our library. Keep an eye on our website, you'll see more in the future. Idaho 2Fly is a group that supports men with cancer through retreats, Zoom meetings, and various other outings that we get together, making men realize that they're not alone in their journey. If you know a man with cancer, have him get on our website, look at our resources, contact us. We'd love to be a help to he and his family.
Thank you very much for attending this video.
I have an interest in cancer. I do a lot of bladder cancer, kidney cancer, testis cancer, and just also general urology. But today I want to focus in on a little bit of a topic that is of interest to many of you, is bladder cancer. So bladder cancer is the fourth leading cause of cancer in men, and so behind lung and prostate, colon, and then it's bladder. And it is the most common site of bladder cancer is the most common site of urinary cancer, and it can occur at any age, but the average age is about 65 years old, and it's more commonly seen in men. More than 90% of primary bladder cancers are considered urothelial carcinomas, and some bladder cancers more rarely are from metastatic lesions from other parts of the body like melanoma or colon. Other less common types of bladder cancer are squamous carcinoma, adenocarcinoma, or small cell carcinoma. As far as risk factors go, a lot of people come in and say, well, why do I have bladder cancer? And some of the main risk factors is smoking. Smoking is the #1 common cause of bladder cancer. And studies have shown that after quitting smoking for 1 year, the risk of bladder cancer actually declines. So if someone's a smoker and they can quit, you can actually make an improvement and decrease your risk for bladder cancer. Other risk factors are chronic infections and indwelling catheters. Those patients who've had chronic bladder or kidney infections or who've require indwelling catheter because they can't urinate on their own. Those patients also have a risk for bladder cancer, and the type of bladder cancer is a little bit different. It's most commonly squamous cell carcinomas. Other chemical exposures in certain occupations like painters or dry cleaners, hairdressers, people who work with leather and dye, tire workers, and textile workers as well. So those are main risk factors, but that being said, I see a lot of patients who, maybe have never smoked, or and I see a lot of women. So even though it's most commonly seen in men and in smokers, there's definitely patients out there who maybe present and they have none of these risk factors. And so that goes into the presentation of bladder cancer. Usually bladder cancer presents as painless hematuria. That's a fancy word for saying there's blood in the urine that I can see, and it's not painful to urinate, but I see it in the toilet. And so other symptoms can be urgency, frequency, got to go to the bathroom all the time. I feel urgency when I go, or maybe it burns to urinate. And oftentimes these patients have gone through, workups with, urine studies, maybe ruling out bladder infections or prostate infections, and they still have symptoms, and those patients can present with those sort of chronic symptoms that eventually lead to further studies. And then more advanced disease, bladder cancer can manifest with back pain or bone pain, especially if somebody has kidney obstruction from bladder cancer or metastasis to their bone from bladder cancer. So if you go to your doctor and say, hey, I've been urinating blood, what would be the next steps? So the next steps would be to visit with the urologist and check the urine, see whether there is blood. We'll do a full exam and sort of talk about your history and your sort of other risk factors. And then part of that workup includes a cystoscopy, which is basically where we place a camera in through the urethra up into the bladder. That is a quick procedure that basically allows us to look inside the bladder, inside the lining of the bladder, to see whether there is bladder cancer or not. And then the other part of that is to do a CT scan, typically imaging, to check to see if there's anything in the bladder or in the kidneys or any lymph nodes that are involved for bladder cancer. Moreover, there's also some lab work that we would obtain to see whether maybe you're anemic or maybe have high calcium or other things like kidney failure, things like that. So once there is a bladder tumor confirmed, and a lot of times people will come in with a CT scan and they say, oh, there's a scan that show there's an abnormality, and we go in there and we confirm that there is a bladder tumor. The next step is to get the pathology. So we need to get a specimen from the bladder to see what the bladder tumor is. So that typically involves an anesthetic procedure where we go in and resect the tissue. So we actually, it's considered a biopsy or a bladder resection, where you go in there and remove the bladder tumor, and typically we try to get it all out. And we also want to get some deeper bites in order to get a good specimen, and that's defined by getting a deep bite into the muscle, and we'll kind of go into that. But the most common, again, pathology that we see is urothelial carcinoma. So when the pathology returns, after that type of procedure is typically an outpatient procedure. Most commonly, patients go home without a catheter. Once in a while there is a catheter involved short term. And the recovery from that is usually pretty straightforward within a couple days to a week. By then the pathology will come back, and what we're looking for is what stage and grade the tumor is. So we want to know if the bladder tumor is a low-grade lesion or a high-grade lesion. Perhaps it's something we call carcinoma in situ, which is sort of a subset of bladder cancer. We also want to monitor, we want to know whether the lesion is just in the lining of the bladder or if it's going deeper into the muscle of the bladder. And that's very important when we talked about getting a good specimen. That means trying to get deeper into the muscle so we know whether it's involving the muscle. Sometimes that requires a second procedure in order to get a good specimen, because the first time around the bladder tumor may be really large and we just want to get it sort of resected down, and the second time we can get deeper bites. So it really depends on where the tumor is and also how big it is, if we can get that in one setting or two settings. Once we know what type of cancer it is, if it's urothelial carcinoma, again, most likely 90% of the time, then the next step is the treatment. So for low-grade tumors, what we do is we typically surveillance those tumors. So if we can get a low-grade tumor resected completely, most commonly we would just follow up with continued cystoscopies. That's where we go in through the bladder, into the bladder, and look around and make sure it doesn't come back. It's really important to understand that for low-grade tumors, about half of those will recur. So I sometimes tell people it's kind of like getting your oil changed. We just got to go back in there and look around and make sure it doesn't come back. It's a little bit of a nuisance, but the procedure itself takes less than a couple minutes, and we're trying to catch those patients. Half of the patients who have a low-grade tumor will have another low-grade tumor sometime in their lifetime, and so we want to go back in there and make sure periodically that the tumor has not recurred. The other thing we want to prevent is that for low-grade tumors, a small subset of those patients will actually progress. So what that means is the tumor has not only recurred, but it actually has gone deeper into the muscle. So that's why, again, close monitoring of these tumors is really important. So for tumors that do recur, or perhaps you have a tumor that has that is high grade, and again, these are high grade tumors that are maybe not into the muscle, we administer a therapy in our office called BCG. So the BCG therapy is essentially an immune therapy. Many people now have heard that immune therapy is just it's an exploding area of oncology. There's just so many new therapies now for all sorts of cancers, especially in urology, kidney cancers, and bladder cancers that are immune therapy based. And interestingly, the BCG therapy has been around for many decades. And so BCG is actually an attenuated live tuberculosis vaccine. So that's been around for 100 years to vaccinate for TB. However, in the 1970s, they found that they could use this to treat bladder cancer. So this is basically a medication that we place, or the vaccine that we place into the bladder through a catheter. And we leave it in for an hour, and then we drain the bladder. And what it does is it basically creates an inflammatory response in your bladder, and so that your own immune system can actually be activated to fight bladder cancer. So even though there's so many new immune therapies now out there for advanced bladder cancer, immune therapy for low-grade bladder cancer, or high-grade recurrent bladder cancer and low-grade recurrent bladder cancer has been around for many decades, and really is quite effective in reducing both the risk of cancer recurrence, meaning reducing the risk of cancer coming back, and also the risk of cancer progressing into deeper portions of the bladder. For higher stage tumors, so tumors that have gone into the muscle of the bladder, so the lining of the muscle, there's the lining of the bladder and then the muscle behind it. So if it's gone into the muscle of the bladder, that's considered a stage 2 tumor. Tumors that are beyond the muscle, outside into the possibly the fat or around the bladder, or even outside of the bladder beyond into the uterus in women, or maybe the prostate in men, those are higher grade, higher stage tumors. The gold standard for these tumors is to remove the bladder, and that is called a cystectomy. So a radical cystectomy in a man involves removing the bladder and the prostate, and in a woman it involves removing the bladder, the uterus, the ovaries, and the anterior vaginal wall. If the patient is unable to undergo such a major procedure, then there are alternatives, including chemotherapy and also radiation, combination chemo and radiation therapies. These are less effective than doing a full removal of the bladder. Usually in the situation where there's a high-grade advanced cancer, there is a role of what we call neoadjuvant chemotherapy. That means that patients will need chemotherapy ahead of time to reduce the risk of spread of cancer, and then subsequently remove their bladder. And then what happens after you remove your bladder is we would have to reconnect your urinary system to divert it to go somewhere else. And how that works is basically we would take the ureters, which is the tubes that drain the kidney, and plug them into a piece of intestine, where we would then divert the urine into the intestines and then bring that out. And that can be done a couple different ways. There's different ways we can divert the urine. There's incontinent ways where you would wear a bag. There's continent diversions where that would include either catheterizing through a channel or actually voiding from below, which is called a neobladder. And the decision between those different types of diversions really depends on the patient's health, and then the location of the tumor as well. The exciting part of bladder cancer really lies in this lies in immune therapy. Going just briefly into immune therapy, because a lot of people will hear about that if you are diagnosed with bladder cancer. The immune system is designed to recognize foreign cells from your own native cells, and it's trying to recognize those harmful cells that are not yours. And it's a very complex system, but in this system there's many checkpoints, and these checkpoints can be, we call them stimulatory checkpoints or inhibitory checkpoints. So basically they're either gas pedals or brake pedals to activate the immune system or hold it back. And so the tricky part with cancer is that these cells have a way to hide from your own immune system. So they have evolved, these cancerous cells have evolved ways to sort of bypass these checkpoints. But these new medications have been recently approved to help fight bladder cancer by affecting the immune response to the cancer cells. So sort of releasing those cancer cells or finding those cancer cells and being able to use your immune system to actively fight those cancer cells. So currently immune therapy is reserved mostly for more advanced bladder cancer patients who have metastatic cancer, who have maybe failed traditional chemotherapy agents. But I think hopefully in the future we can see the immune therapy treatments sort of expand to maybe more primary low-grade cancers, or maybe cancers which are high-grade muscle-invasive cancers that have not spread, and hopefully avoid potentially removing your bladder and having to go through a major abdominal surgery. So that's the exciting thing about bladder cancer right now.